Okay. This patient, this patient with prolonged house fire exposure likely has cyanide poisoning. Cyanide is a toxin. Cyanide is a toxin released during combustion of the household items, plastic, polyurethane mattress that contain carbon and nitrogen. Cyanide inhibits oxidative phosphorylation and halting aerobic metabolism and forcing a switch to anaerobic metabolism that results in lactic acidosis. pH 7.15 lactic acid 25 tissues cannot tissues cannot effectively use oxygen because tissues cannot effectively use oxygen. Venous blood venous blood remains unsaturated with oxygen and appears bright red causing reddish colored skin. Early early acute toxicity causes cardiorespiratory stimulation, tachypnea, tachycardia, but a cardiovascular collapse rapidly occurs unless treatment is administered. Cyanide poisoning must be empirically treated, but serum cyanide levels cannot be measured quickly. Hydroxycobalamin, hydroxycobalamin, the preferred treatment, binds to intracellular cyanide and forms cyanocobalamin, which can be renally excreted. Sodium thiosulfate, which acts as a sulfur donor that detoxifies cyanide to thiocyanate and is sometimes administered and is sometimes detoxifies a cyanide to thiocyanate and is administered with hydroxycobalamin. In addition, treatment with 100% oxygen is continued to maximize oxygen delivery to tissues and to treat concomitant carbon monoxide poisoning, a common result of house of fire exposure, typically associated with elevated carboxyhemoglobin level. Okay, option C, methemoglobinemia. Methemoglobinemia, which alters the hemoglobin and decreases its capacity to deliver oxygen to peripheral tissue, can present with coma and metabolic acidosis. However, cyanosis versus reddish skin and decreased pulse oximetry reading that does not resolve with supplemental oxygen due to methemoglobin light absorption, and are usually and are also typically present. In addition, methemoglobinemia is usually associated with exposure to oxidizing agent like dapsone, nitrates, and topical anesthetics. Okay, how you differentiate these two, like cyanide and carbon monoxide poisoning? Cyanide and carbon monoxide poisoning both are like uh, house fire, like gas, or like in the backyard of every house there is parking a garage area where uh, this is one of the risk factor, like parking area. If somebody opens the car, or then cyanide or carbon monoxide poisoning happens. You got my. Yes, yes, yes. Like and black suit, is it a key point, like this? Empirically, the, yes, cyanide. I know that, like these two things has two different treatment. Like carbon monoxide is like 100% oxygen, hyperbaric oxygen chamber, and cyanide poisoning like uh, again oxygen, but hydroxycobalamin, sodium thiosulfate. These are the treatment. But methemoglobinemia is like cyanide poisoning. We actually give hydroxycobalamin, or sorry, we actually give sodium thiosulfate to form it methemoglobin, which is not that bad like cyanide poisoning. There is something like that. Okay, yes, next. Okay. This patient has likely has hereditary angioedema, a condition characterized by recurrent edema without associated pruritus or urticaria. Deficiency of or dysfunction of C1 inhibitor leads to elevated bradykinin, which causes edema due to vasodilation and increased vascular permeability. Although autosomal dominant inheritance is most common, up to 25% patients have de novo mutation with no family history of the disorder. Hereditary angioedema hereditary angioedema typically presents with mm, hereditary angioedema typically presents in childhood and adolescence with acute onset cutaneous swelling, often after emotional stress or trauma, dental procedure. The face, limbs, and genitalia are most commonly affected, and pruritus and urticaria are absent. Bowel wall edema can also occur, and presence as colicky, abdominal pain, vomiting, diarrhea, less commonly progressive laryngeal edema, and can lead to life-threatening airway obstruction. Most episodes of angioedema self-resolve in 2 to 5 days. However, acute treatment C1 esterase inhibitor is typically recommended to prevent airway involvement. Okay? Yes. Hereditary angioedema, it's an autosomal dominant or de novo mutation. Autosomal dominant de novo mutation. C1 inhibitor deficiency or dysfunction. Excessive bradykinin fluid extravasation into skin and mucosal tissue and bowel wall, upper airway, cutaneous swelling, face, extremity, genitalia, no urticaria or pruritus, no identifiable trigger, mm, AC inhibitor or NSAIDs, colic abdominal pain, laryngospasm, and airway obstruction, decreased C4 level, and decreased C1 inhibitor protein or function. Acute management is C1 inhibitor concentrate, bradykinin antagonist, icatibant, and kallikrein inhibitor like ecallantide. So yes, okay. Mm.
Prior exam.
Okay. And this patient developed fever, arthalgia. This patient developed fever, arthalgia, urticarial rash, and mild proteinuria while taking the chimeric monoclonal antibody infliximab. Chimeric and humanized monoclonal antibodies contain foreign bodies derived from other animals, that is, mice. Exposure to foreign proteins triggers an adaptive immune response markers by the generation of high affinity antibodies. Binding of the high affinity antibodies to the foreign protein to the medication generates immune complex, which are subsequently cleared by mononuclear cells in the reticuloendothelial system. Although the formation and the removal of immune complex often proceeds without symptoms, large quantities of immune complex can saturate large quantities of immune complex can saturate the phagocytic system, lead to immune complex aggregation. The aggregated immune complex can then deposit the tissue, skin, joints, glomeruli, activate the classic complement system, and can cause type 3 hypersensitivity reaction called serum sickness. Common manifestations include fever, urticarial rash, arthalgia, and mild proteinuria. These symptoms resolve spontaneously as the immune complex are cleared, but patients may develop recurrent symptoms 5 to 14 days after each dose of the medication. In addition to the monoclonal antibody, antitoxin, antivenom, or antigenic vaccines can cause serum sickness reaction. Some antibodies can cause serum sickness like reaction, and that is not due to high immune complex titers.
Can you repeat?
IgE can form against chimeric antibody. IgE can form against chimeric antibodies and trigger urticarial rash upon re-exposure to the mast cell and basophil degranulation. However, fever, arthalgia, and proteinuria would be somewhat atypical. In addition, type 1 reaction typically begin within minutes of drug infusion.
67 by enlarging the is it the hyponatremia?
No, sodium causes seizure.
Oh. Mm,
Sodium for
no.
CNS, potassium for heart arrhythmia.
Sodium plus CNS.
Why uremia? Creatinine is not that high. Okay, this patient with altered mental status is on morphine therapy. If somebody has impaired kidney function, like opioid medication in patients with impaired kidney function, like morphine, meperidine, codeine, and tramadol, these four drugs is avoided with impaired kidney function. So this patient with altered mental status is on morphine therapy, has concurrent renal insufficiency, possibly due to progressive multiple myeloma. These presentation raises suspicion of opioid intoxication. Morphine is the first metabolized in liver, producing active metabolites retaining mu opioid agonist activities such as morphine 6 glucuronide that are renally excreted. In patients with impaired kidney function, such as these patient, accumulation of these metabolites are on this accumulation of these metabolites can lead to altered mental status, sedation, and respiratory depression. Several other opioids, codeine, meperidine, also have active metabolites not that are renally excreted and should be avoided in patients with, and it should be avoided in patients with renal insufficiency. Opioids that have inactive metabolites, opioids that have inactive metabolites, fentanyl, that are not dependent on excretion by the kidneys, methadone are preferred. Okay. Yes, severe hyponatremia can cause altered mental status uh, and weakness, but these patients' moderate hyponatremia is unlikely to cause such symptoms. So severe hyponatremia can, I was wrong. Multiple myeloma can cause pseudo hyponatremia due to displacements of water by high globulin content in the blood, but this is lab artifact, not true hyponatremia, and would not cause symptoms. And uremia, characterized by fluid and metabolic abnormalities to have advanced kidney disease, can cause altered mental status. However, symptoms usually occur when creatinine clearance is extremely low. When creatinine clearance is extremely low, less than 10 ml per minute, generally seen in with very high creatinine level and are typically associated with markedly elevated BUN levels more than 50 milligram per deciliter. Uremia is unlikely in this patient with moderate renal efficiency and only mild elevated BUN. Okay, potassium for the heart, kalemia for the arrhythmia, sodium for CNS. If you find like Caesar in any question, if there is hyponatremia, it is mainly the cause. So sodium for CNS, potassium for heart, potassium, kalemia, causing arrhythmia, like hyperkalemia or even hypokalemia can cause arrhythmia. You okay?
Thinking at lunch.
Lactic acid is high. Okay. Is it bicarbonate is low? Is it metabolic acidosis? Mm, in metabolic acidosis, mud pile, methanol, uremia, diabetic, propalone, isoniazid, ethanol. Mm, maybe. Yes. Yes. Like mud pile, in mud pile, the final S is salicylate. No clue in the question. I haven't found any clue. Yes. And another important is no pH is present. So how we can calculate? Like if I don't see the bicarbonate and lactic acid, there is no other way of finding this. Okay. My brother was talking. He said, "Hey Maria." Okay. Oh, okay. As I am from Muslim family, like Islamic Muslim family, so it is very restricted to talk with the girl. That's why. That's he just came now. Okay. Okay. So that's why he make fun of me. Okay. Okay. Explanation. This patient's confusion, hyperarrhythmia. Sorry, this patient's confusion, hyperthermia, tachypnea, elevated lactate, and anaerobic metabolic acidosis raise suspicion for acute salicylate toxicity. Acute salicylate toxicity. In most cases are caused by excessive ingestion of aspirin, also as it can also be seen due to overuse of other salicylate products and oil of wintergreen methyl salicylate. I don't know what is oil of wintergreen is. Okay, toxic quantities of salicylates uh, quickly overwhelms the overwhelms the ability of liver to metabolize the compound, which prompts the prolonged serum elevation of the drug due to slower renal excretion. Patients usually have the following manifestation: nausea, vomiting, epigastric pain due to stimulation of chemoreceptor trigger zone in the medulla, and irritation of the gastric mucosa, and reduce epithelial prostaglandin production, hyperventilation due to stimulation of the respiratory center in the medulla, and metabolic acidosis due to interference with the Krebs cycle, and oxidative phosphorylation, which leads to lactic acidosis and hyperthermia, and confusion due to neuroglycopenia and cerebral edema. Tinnitus uh, also commonly occurs. The diagnosis is made with serum salicylate level. Treatment includes supportive therapy and activated charcoal if aspirin was ingested. CT mesenteric angiogram can cause acute mesenteric ischemia, which often cause severe abdominal pain, nausea, vomiting, lactic acidosis, tachypnea. Lactic acidosis, however, tachypnea, hyperthermia, and confusion are less common. In addition, most patients have a risk factor for acute embolism, such as atrial fibrillation. Okay, salicylate toxicity. Excess ingestion of aspirin. Excess ingestion of aspirin or other salicylate like oil of wintergreen. Liver metabolism gets overwhelmed, slowed renal excretion, prolonged elevated salicylate level. There may be nausea, vomiting, hyperventilation, hyperthermia, altered mental status, and metabolic acidosis. Diagnosis is done by doing serum salicylate level, activated charcoal in alert patient with 2 hours of ingestion. IV sodium bicarb enhances salicylate excretion and hemodialysis for severe ingestion and pulmonary edema, renal failure. Okay. Uh, Energy production like salicylate, the byproducts causing the energy production. Uh, Maybe salicylate works on the maybe Krebs cycle where there is a breakdown of mitochondrial ATP and thus causing the heat production. Maybe I need to see the explanation then. Confusion due to cerebral edema or neuroglycopenia. That means the neuron is not getting glucose, maybe. Okay. In frostbite, first the rapid rewarming in the water bath, then angiography to look for thrombosis, and then thrombolysis, and finally the amputation. Isn't it? Is this the serial?
Repeat.
First repeat rewarming, then angiography, like repeat rewarming along with if there is pain, analgesia, and wound care. And if rewarming failed, then angiography for to look for thrombosis. If there is thrombosis, give thrombolysis, and finally the amputation. Okay, frostbite is characterized by freezing of tissue leading to disruption of cell membrane, ischemia, vascular thrombosis, and inflammatory change. Severity can range from superficial pallor. Severity severity can cause superficial pallor and anesthesia to blistering, scar formation, or deep tissue necrosis and mummification. Affected tissue typically have a stiff or waxy texture. Most cases involve the face, ear, and distal limbs. Initial management of frostbite is based on rewarming in 37 to 39 degrees Celsius water bath. Aggressive analgesia should be offered due to potential of severe pain in the rewarming process. Hot air rewarming is not recommended. Hot air rewarming is not recommended due to difficulty of maintaining precise temperature control. In the field of rewarming can be accomplished by holding the affected limb against the rescuer's abdomen. However, it should not be attempted if there is a possibility of refreezing before definitive care be provided, as it can worsen the tissue damage. After rewarming, careful wound care should be provided to reduce the risk of secondary infection. Okay. Uh, severe frostbite severe frostbite injuries may require multiple debridement or procedure, but initial assessment may overestimate the extent of the tissue damage. Debridement is not indicated until the tissue is rewarmed and accurate survey of devitalized tissue can be performed. An IV intravenous infusion of warm fluid is indicated in the management of systemic hypothermia, but it is not effective in frostbite injury. It is like, think about in that way. If no oropharyngeal problem, no striator, So we so it is not anaphylaxis. So the next thing you need to rule out either it is urticaria or a large local reaction, isn't it? In both the cases, in urticaria local reaction, we give antihistamine steroid. Okay. This patient has developed this patient has developed a local allergic response, swelling and erythema contiguous to the site of the sting, contiguous to the site of the sting to multiple sting from from imported fire and IFA bites. Local and systemic reaction can occur in response to sting. Will and flare reactions occur within a few minutes of the encounter and are accompanied by a burning, stinging pain. Sterile pustules often develop within hours due to venom alkaloids. They should be left intact. Will they should be left intact. Will resolve within a week. Will resolve within a week. These minor reactions do not require treatment. Large local reaction as seen in this patient are exaggerated large Ig-mediated response to proteins. Proteins in the venom IFA characterized by erythema, worm, swelling. Large local reaction develop within first 24 hours in this case and extend to 10 centimeter or more contiguously from the site of sting. Swelling can be significant enough to cause vascular compromise, absent in this patient with normal perfusion and sensation, but this is rare. The lesion contains fibrin, eosinophil, neutrophil lymphocyte. They are treated with topical high-potency corticosteroid clobetasol 0.5%, clobetasol 0.5% ointment and oral antihistamine. In patients with severe local symptoms, short course of oral prednisolone can be prescribed. Okay, okay, I'm coming. 2 minutes. Okay.
When the young boy brought to the eating for company
Is it B cell problem or is it on other problem? Giardia infection.
Giardia is what? It's not bacteria.
Yes.
Is it
No, no, no. Giardia is protozoa. It's B. Yes, it's Brutons. Our Brutons. Yes, recurrent infection from starting from 6 months. Medical history. Yes, yes, absent B cell. Like it has no B cell, no plasma cell, no antibody, and CVID problem in the differentiation. L- Yes, this patient, this patient has this patient's recurrent pneumonia, giardia infection, small giardia infection, and small tonsils are suggestive of X-linked agammaglobulinemia. Or Bruton's agammaglobulinemia, X-linked agammaglobulinemia is caused by genetic defect in Bruton kinase, resulting in abnormal B lymphocyte maturation. Low B cell concentration lead to small or absent lymphoid tissue, tonsil, adenoid, and severely decrease in immunoglobulin concentration due to impaired humoral immunity response. Infants with X-linked agammaglobulinemia are predisposed to recurrent cytopulmonary infection, that is otitis media pneumonia, with encapsulated organisms such as Haemophilus influenzae, Streptococcus pneumoniae. The absence of IgA also increases the risk of gastrointestinal infection. Giardia patients usually become infected after 3 to 6 months when protection from maternally acquired IgG begins to wane. X-linked gamma globulinemia is immunoglobulin replacement therapy. Prophylactic antibiotic may be one entity if IV immunoglobulin is unsuccessful. Live vaccines are contraindicated in X-linked gamma globulinemia, and other vaccines are not contraindicated but do not generate an effective antibody response. Okay. Thymic hypoplasia is DiGeorge syndrome, which is characterized by hypocalcemia, cardiac death, failure to thrive, in addition in addition to recurrent infection.
Between months.
Recurrent bacterial infection like pneumonia and enteroviral meningitis is only one.
Interferon gamma receptors.
No, he has only B cell problem. Yes, BTK is a very tough topic. This question is very hard, like Brutons and CVID. I got fixed in between these two. Okay, so enteroviral meningitis is specific for BTK. It is written in first aid, recurrent bacterial and enteroviral infection. This patient has this patient has chronic this patient has chronic enteroviral meningitis. This patient has chronic enteroviral meningitis and recurrent pneumonia, which are features of X-linked agammaglobulinemia. X-linked agammaglobulinemia is an immunodeficiency characterized by failure of B cell maturation in the bone marrow due to defective BTK kinase gene signaling. B lymphocyte cannot enter into the circulation, resulting in decreased antibody response and resulting in decreased antibody production and impaired humoral immunity. X-linked agammaglobulinemia causes recurrent infection in boys during late infancy. Once maternally derived IgG wanes age more than 3 to 6 months, Sinopulmonary infection are most common and are typically caused by encapsulated bacteria, Streptococcus pneumoniae, Haemophilus influenzae type B, which require antibody opsonization or clearance. Patients are also predisposed to chronic enteroviral infection. Meningoencephalitis are seen in this patient due to lack of antibodies to neutralize disease. Similarly, prolonged diarrheal illness (giardia). Similarly, prolonged diarrheal illness (giardia) due to low IgA and more likely in X-linked agammaglobulinemia. Lab finding of X-linked agammaglobulinemia: low CD19 B cell concentration, decreased level of all immunoglobulins. Antibody response to vaccines is limited. Immunoglobulin replacement therapy is the mainstay of treatment. Okay. Intracellular killing of microbacteria is activated by interaction of interferon gamma, which is released by the T cell and NK cell, and interferon receptors of the macrophage. Interferon receptor deficiency results in disseminated microbacterial disease beginning in infancy. Okay, can you tell me this flow chart, like what happens in here? Okay. X-linked agammaglobulinemia BTK gene mutation resulting in defective Bruton kinase, impaired B cell maturation and immunoglobulin production, recurrent sinopulmonary and GI infection at age 3 to 6 months, chronic interval infection, small or absent lymphoid tissue, tonsils, adenoid, decreased immunoglobulin, and antibody response to vaccine flow, cytometric decrease CD19 non B cell and normal T cell. Okay.
Why contact online?
Uh, have you done your breakfast? My brother came, so I need uh, 10 to 15 minutes.
Yes.
So, you do your breakfast, then we can continue. Then we can.
Okay.
Okay. Okay. Thank you. Okay.